Good morning and welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is adherence to disease-modifying therapies in MS. Our presenters for today's webinar are Dr. Terry Schreiner, an MS specialist physician at the Rocky Mountain MS Center Clinic at the University of Colorado Hospital's Anschutz Medical Campus, and Patricia Daly, a licensed clinical social worker with more than 20 years' experience treating MS patients and their families. We will also be joined by two patient advocates this morning, Cassandra and Susan. The webinar is scheduled for 1 hour. The first 45 minutes will be a presentation and discussion by our panel, and the last 15 minutes will be reserved for questions from the audience. You can submit a question at any time during the hour by entering it in the chat window you see on your screen. Thanks so much for joining us today. Now here's Dr. Schreiner to get us started.
Good morning and welcome. This is Terry Schreiner, and I'm happy to be here today with my panelists to discuss a very important topic in the field of multiple sclerosis, specifically the use of disease-modifying therapies to treat MS and adherence to those medications. I have prepared some slides that I would like to use as a outline from which we might have further and more casual discussion about the different aspects of adherence to medications. I believe you all have the opportunity to send in questions as we go, and I would invite you to do so. And likewise, I will invite my panelists to participate freely so that we might have a discussion about these different aspects of adherence from people who are living with the challenge daily. So, let me provide first just an outline of some of the topics I'd like to touch on. Again, not necessarily in this order, but I'll provide a little bit of background. We'll talk about some of the factors that influence adherence, including your relationship with your physician and choice of medicine, whether or not you feel the medicine is working, whether there are other methods of treatment that you're using, the cost of medications, as unfortunately this can alter adherence to them, and then tolerability issues, including cognitive issues as well. So let's move forward and talk a little bit about what adherence is. And this is a very textbook definition, but truly adherence just means whether or not your behavior agrees with the recommendation of the medical community with regards to the medicine we're talking about. And this is not an issue specific to multiple sclerosis. It matters for all diseases and all medicines. The World Health Organization did a study recently among adults with chronic diseases and found that up to 50% of people are adherent. And said a different way, that means that about 50% are not adherent to their medications. One of the challenges in monitoring adherence is that many of the studies that we have, as well as many of the interactions between doctors and physicians, are influenced by reporting bias, which means that it is human nature to over-report compliance, and that is something that we're all aware of, but I would encourage us all as we go forward to think about frank discussions with physicians on these topics.
So one of the ways they have monitored adherence is they have electronic monitors that they can put on people. And so some of the data and the categories of adherence that are on the screen now come from electronic monitors that reveal really interesting behavior about how people take their medication. And one of the things that I think is really interesting is that people are much better about taking their medication 5 days before they see the doctor.
Yes, and maybe 5 days
and
after.
5 days, and maybe up to a month after.
Okay.
The behavior gets really good, and then it tends to change.
Yeah, yeah.
And I was really surprised to hear that.
Yeah. There's also evidence that the adherence, how well and you're taking your medicine as prescribed, it sort of wanes with the length of time that you've had the disease. So the longer you've had it, the less likely you are to be adherent to how it's prescribed for a variety of reasons. On the screen, you see sort of categories of adherence, starting all the way at the top with, doing everything perfectly all the time, going all the way down to the bottom, which is, non-adherent, not taking the medicine. And in this category as well, I think it's important to recognize that discontinuation of therapy is a form of non-adherence as well, so just stopping the medicine.
So this is Pat, and I just wanted to add another point there. What I was surprised about when I was researching this was the fact that patients are often not honest about their adherence behavior. So sometimes people who are taking no medication at all pretend like they are, which is why this is such a complicated topic, in fact.
Right. Absolutely. Okay, I have a little bit more information I can provide on some of the studies that have been done in adherence, specifically in the population of MS. Susan, Cassandra, anything to add before I can get going with that?
I would just say, when we start talking about the relationship that you have with your physician, whether it's a neurologist or other people on your care team, you do have, or at least I do, want to tell them that I'm doing what I'm supposed to be doing, even if I'm not. So I do think that the studies definitely are accurate in terms of what the experience is from a patient perspective.
Okay, so adherence in MS. So there's several studies that have been done looking specifically at this, and most of them have looked specifically at adherence to some of the older medicines, so the injectable medicines, specifically Copaxone and the interferons. And so that's important as we think about this data, because nowadays, thankfully, we have many more options, including oral options and infusions. And so thinking about these studies as adherence to all modes of treatment of MS is not really applicable. What we've found is that there is a wide range of adherence among the MS population, with some studies showing that 75% of patients are adherent, are taking their medicine as prescribed. Said differently, 25% are not, when other studies show 40% perfect adherence and 60% somewhat less than that. Multinational studies have been done, and so the range it reflects different cultures as well as different treating paradigms, different physicians. Now, why it matters. So it matters because we care about how our patients do, and we want our patients to do well physically, and that means, taking these medicines, which we believe will influence the course of a disease in a positive manner. There's also a cost perspective as well, and that is that not only is it lousy to have a new neurologic symptom that pulls you out of your life, out of your ability to work, participate in family, etc., but it can also be costly. So you have lost wages, trips to emergency departments, infusions, and sometimes even hospitalizations. And so these are the things that we are trying to avoid, disability as well as all of those costs with promoting adherence. commonly cited reasons for not being adherent include both side effects and adverse reactions or adverse events. And these are slightly different. Side effects we kind of expect, unfortunately. So they are any effect of the drug that is not preventing or working to minimize risk of relapse in MS. And a common example is the injection site reactions with Copaxone. We know they happen, we don't like it, but that is sort of an expected part of the drug, unfortunately. Similarly, like the flu-like side effects with interferons and with some of the oral medicines now, like dimethyl fumarate, we kind of expect that in the first month some people will have stomach upset. But an adverse reaction is a little bit different, and this is less common, but tends to be more severe, and it is an undesirable effect of something that the drug is doing. So my example there is with rituximab, which is a medicine that specifically targets one arm of the immune system. You are targeting that arm to prevent relapses, but you're also going to be more prone for infections like urinary tract infections and upper respiratory tract infections because of what you're doing. So these are things that I hear about commonly, and we'll come back to those unless, Pat, do you have a comment?
Yeah, I have a comment. I think it's confusing sometimes the difference between side effects and adverse reactions, and my experience is that side effects are what trouble patients. So injection site reactions and flu-like side effects, but they don't threaten your overall health. So sometimes I think physicians can seem to be dismissive about side effects, and I've heard those things referred to as nuisance side effects. And because they're not life-threatening. Adverse events are life-threatening, and that's what really worries your doctor. But what really worries you and is a concern, I think, for adherence and promotes non-adherence are the side effects. The point being that sometimes you have to really stress if side effects are going to stop you from taking your medication, that it really is a big deal for you, even if it's a nuisance side effect.
No, I think that's a really important point. And maybe we can take this opportunity now to go to Cassandra. I know you've had experience with many, at least 3 of the injectable medicines and have had side effects and perhaps even adverse reactions from them. Can you tell us a little bit about your experience with those and how that altered your thinking about adherence?
Yeah, sure. So this is Cassandra. I started on Adherence. I was diagnosed in 2001, and I started first with Adherence even really before I got a definitive diagnosis. And I was on Adherence for, I think, 2 to 3 years. I did experience the flu-like symptoms every time I took an injection. So I know most people, if they have that experience, they tend to adjust to it, or, it's not as bad, or it just seems to go away after a while. But for me, the entire time I had it, I always had that. And then so that was one of the reasons why I actually explored moving to Copaxone instead. Because after a few years, I just really wasn't able to take my Adherence consistently because I was it started to really interfere with my, with my daily activities. So I moved to Copaxone, and I had a really good experience with Copaxone. I was on that for a couple of years as well. I had some of the injection site reactions, but it wasn't, it didn't discourage me at all. I felt like it was, part of the process, and so it really wasn't until I started to get another side effect, which is, I think, also a little bit uncommon, but kind of that flushing sensation. I started to get that several times, but after I had been on the medication for at least a year. So then I was interested in moving to Rebif, and I tried Rebif. And again, I had less of a reaction than I did to the Adherence, but I also had the flu-like symptoms again that I didn't recover from. So I was on that for a while, but I ended up taking time off of work because I was working full-time through all of this. And I ended up having to take time off of work because the side effects were so invasive, I guess, to the rest of my routine.
Yeah, I was just going to agree with you, Cassandra. We must have very similar experiences because I started on Adherence as well. This is Susan, and it affected my life so much that I actually couldn't, like you said, was taking time off of work. I was doing the injections on Friday evenings, and then I was sick for the entire weekend. And at that time, my physician, really nice guy, but really did not understand. My neurologist didn't really understand how much it was affecting my life. And to Pat's point, started talking about, that, well, just take some aspirin or some Tylenol and you'll be able to sleep through it. But I after 6 months, just could not, I actually didn't even want to get up anymore during the week because it took so long just to get it out of my system. And then I switched to Copaxone as well, and had the injection site reactions, and I was adherent to the medication. However, I do think that there was some downplay of how difficult that is as well. For example, I couldn't wear a bathing suit for 2 years because I had bruises all over where I was scratching the injection site. So I think all of these things sort of play into, how you take the medication and whether or not you want to take it. So.
Well, and I think, thank you for sharing. I had a couple thoughts as I was listening to you talk, and one was, Cassandra, I think you've described this sort of flushing reaction with Copaxone. It's actually been described to me as like you think you are dying, and this is an overwhelming feeling of doom, and your heart races and you're flushed, and it's really, really miserable.
Yes, and then if your doctor says that's a nuisance side effect and you just thought you were going to die, it's a little bit of a disconnect. It can be a problem long term for the relationship.
Yeah, no, I think that's a significant thing to take to try and convince yourself of when you're giving yourself these injections, that this is actually worth it, even though I may feel like I'm going to die afterwards. The second thought that I had is, when the medicine that is supposed to be keeping you in your life and, so to speak, protecting you is actually pulling you out of your life because you feel like you have the flu for 2 or 3 days out of 7.
On the weekend when you're supposed to be having fun.
Right, on the weekend. I think that's a horrible trade-off, and I'm so pleased that we have better options now, but truly, I could see how that feeling of misery, it would be a real struggle to convince yourself every week that this really is worth it. This is something that is going to make a difference for me.
I think we do need to put in a point here that not everybody has the same side effects.
Right.
And the side effect profile for people is very different. So some people don't have flu-like side effects every day of the world.
Yeah,
people do get used to it, but some people don't.
Yep. Yeah. And thankfully so.
Yeah, I could jump in. This is Cassandra. I think that's a really interesting point. I remember, this might be premature because I know we'll get to more of this later in the conversation as well, but I remember talking to a lot of people about, sticking with the meds and just trying different meds because I wanted to find the one that was going to, be effective for me but be the least disruptive for my life. And honestly, my disease has really been pretty mild. And so, I've been full-time employed ever since I was diagnosed, and I've had some pretty stressful positions, and I've been able to manage all of that. It was the side effects of the drugs that I wasn't able to manage along with my lifestyle. So, that for me was a really interesting dilemma to face, is that, the disease that I was actually experiencing and the effects of the disease that I was actually experiencing were far less intrusive than the drugs themselves. So that's always been kind of a difficult balance to strike.
Yeah, absolutely. And part of the reason you take the medicine is to prevent exacerbation. So if it's working really well, then you're feeling no effects of the disease, but you're feeling every one of the effect of the drug. And so that's a really hard balance. Why don't we talk ever so briefly about why we treat MS in the first place? Just, I think we're all on that bandwagon, but we know that MS is a chronic disease. We don't yet have a cure, and it is comprised of really two components, one of which are these exacerbations that come and cause symptoms of weakness or numbness or vision change. And the other aspect of the disease is sort of the chronic indolent inflammation that we think over decades can contribute to disability. And so the reason we treat is really to try and come at both of those aspects of the disease and try to minimize them. And all of the medicines work by changing the immune system response to try and interrupt the MS process. And it isn't just medicines that we use to treat MS. We also have non-medical therapies, and I think that there are treatments, and that's important to remember as well, is it's just not all about the drugs. Lifestyle changes are equally important, and in many cases, they're equally difficult to be adherent to for different reasons. But they do comprise an important part of treatment of MS. And as I've said before, thankfully now we have many different treatment options where it's no longer just the injections that you see on the left side of your screen, but also oral medications and infusions. And we have some newer modes of delivery of older drugs. And so now Copaxone, which used to be an everyday drug, now can be given 3 times per week. And I've left this nuance off, but we now have an Adherence that can be given every other week. So there are improvements being made all around in terms of the medicines that we use. Why don't we talk a little bit about the doctor-patient relationship? And maybe, Susan, I'll go to you first to tell us a little bit about your experience and how that influenced your choice of medicine.
Sure. I was initially diagnosed after a bout in the hospital for a week. And I had double vision one morning, felt great otherwise, but couldn't see, and went to the emergency room, and they thought I had had a stroke. And what turned out to be, what I thought was a migraine, turned out to be a week in the hospital. And at the end of that week, I feel somewhat fortunate that I was diagnosed quickly, but I was still diagnosed and had no understanding of what this was at all. The physician or the neurologist that I had from the hospital said, come back in 7 weeks, we'll figure out what to do. There's probably a good chance that you'll have something else in the future. And that was kind of my first introduction to MS. So I think that point being that, I think it's really important to shop around for your doctor. Sometimes there's a group of women, we all have MS, and we meet, and it's interesting to talk because we're all so different. And like we were just talking about with the medications, we all react differently to the medications. We all take them differently. But the one thing that we've talked about a lot is our physician relationship. And the last time we were together, I likened it, maybe this isn't a great analogy, but I likened it a little bit to your financial risk score. So if you feel like, like if you're in the stock market and you feel like you're a really aggressive, trader, then you're probably going to want a physician, or at least it seemed like out of this group of women that you generally were with a physician who wanted to be really aggressive about your treatment. There were some women in our group that they really love their physicians, but are definitely more conservative about what they actually want to take, or the different treatments, or they're okay with a few new lesions, that type of thing. Whereas my physician relationship with Dr. Miravalli at the Rocky Mountain MS Center is we're both kind of on the same page about, I want to treat this very aggressively. He says no new lesions. And so typically if there are new lesions, we generally agree together that, there are probably some issues with the medication. And so we've continued to just sort of change things. I won't say that that's been an easy decision each time, but I think the relationship with him is such that, I can say to him, I'm not okay with switching for another 6 months. Let's see what happens. Or I am okay with us because I know that you're trying to have no new lesions. So I think it's just really important to shop around. One woman that's in our group, we were talking the other day, and she had never switched doctors from the first doctor that she saw, and she was surprised as we did a poll around the room at dinner. She was surprised that most of us had 3 to 4 neurologists, and I think we've all been diagnosed like anywhere from 5 years to 8 years. So I just think it's important to really find somebody that you have a good relationship with. I'll say too that I have a really great primary care physician, and she knows about MS. She's not part of the University of Colorado, but she knows Dr. Miravalli and has communicated with him. And so I think the questions that, I don't necessarily ask him, I'll ask her, and vice versa. So I think it's really important to have that aspect, of your care team.
Oh, yeah, absolutely. Yeah.
And therapy. Therapy is always a good thing too.
Yes, absolutely. No, it really does take a village, so to speak.
Yeah.
And it's not just your neurologist, but in thinking about, these medicines, it does come down a lot to your connection and your trust, I think, with that physician. And the fit.
Yeah.
Because this is Pat. One of the things that you said that's really important is that you and your physician are on the same page about how you want to treat this, and that you have good information about your options for treating this.
Right. I think the education piece is extremely important as well, because like what we were talking about with the medications earlier, if it does make you feel like you can't get up on the weekend or something like that, you need somebody to be able to give you education and information about what the medications are actually doing. Because I think when you're first diagnosed, you think that they're going to take away symptoms. Regardless of what the physician tells you, you still kind of think that. And so it's easier if you understand. It's easier to be adherent if you understand what this is doing in the long term, and then to also just really figure out what that best fit is with your doctor and with your medication. The education is extremely important. Go ahead,
Cassandra.
Yeah, I just wanted to add that I totally agree with everything that Susan just said, and I too have had several neurologists. I think that the importance of shopping around is really critical to making sure that you understand as a patient what's happening, but also that we feel free to grow. So, I was 24 when I was diagnosed, and what I needed from a neurologist when I was 24 is very, very different than what I need from a neurologist at 38. So the questions I have are different. The relationship I need is different. So in the interest of full disclosure, Dr. Schreiner is my neurologist, and she's
I wasn't going to ask you about that, but yeah.
But I was actually just talking to my husband about this a couple of days ago, that what I need right now is I need Dr. Schreiner. I don't necessarily need the great neurologist that I was working with 10 years ago. I mean, he was wonderful, and he really helped me understand the importance of meds, and actually that's probably why I got through some of the side effects of those meds for so long, is because that approach that he took with me was a lot more just sort of matter of fact, and said, this is what you really need to do in order to have long-term success with this disease, and the earlier you're compliant, the better it is for you and for your outcomes. But now if somebody said that to me I have so many other considerations in my life. I'm not sure that I would hear that message as well. So, just not only shopping around, but really understanding who you are as a person and as a patient, that changes. And your growth, if your neurologist isn't growing along with you and your relationship is changing, then it's okay to find the right person because they're willing to look at other options for you. And that's what I get now with Dr. Schreiner is I get somebody who's willing to be my partner, who's willing to talk to me about the pros and the cons, who's willing to listen to all of my concerns and really, not only listens to them, but takes them into effect when she gives me recommendations, and then accepts my decisions, even if they're not the decisions she would make for herself or for me. So that's what I've kind of grown into now and what I really need more than I did before.
Thank you, by the way.
Someone told me one time when I had an infant and we were talking about pediatricians, and she said, your pediatrician is the person who's there to teach you how to manage this baby. And I think that's true about neurologists too, that they're here to teach you how to manage your MS. And so I think your point, Cassandra, is a really good one. What you need when your MS is in its infancy is really different than when you have teenage MS. It's just different.
Right.
Yeah. Well, yeah, and thank you for those thoughts. I mean, I think that's a really wonderful thing to think about is how the relationship changes. And one of the things that I learned as I was reading through some of the research that's been done in this area is that they have correlated in some of these large studies the number of minutes that are spent with a patient with MS at the time of diagnosis and with subsequent adherence. So I thought that was really interesting, and that's sort of been a point that I think I'm going to take because there's so much to talk about in the very beginning. There might have to be ways to try and squeeze in a couple more minutes.
Yes, well, can I make a plug for MS 101 and the program that we do at the Rocky Mountain MS Center, which is an opportunity for patients to get all of their questions answered, which I think in a way that is tailored to the newly diagnosed patient who doesn't know much about MS.
Mm-hmm.
When you've had it for a while, you get pretty sophisticated and you can ask much different questions than you can ask when you're newly diagnosed. And it's critical to have that background information going into these discussions. And it's just really hard to get because it takes a lot of time.
Mm-hmm. Yeah, and I think that's a squeeze that we all feel. There's so much to talk about and not enough time to talk about it, but it is important. Why don't we talk a little bit about, we've kind of already gotten to tolerability. Why don't we talk about whether or not alternative methods of treatment have played a role for you, either Susan or Cassandra, and whether or not you've struggled with that perceived lack of efficacy. I don't know if this is doing anything for me. Do I really want to continue going down this path?
I'll start. So in terms of I'm not having exacerbation, therefore I don't need a disease modifying. I think that I don't know about you, Cassandra, but that has crossed my mind several times. However, because I've had Dr. Miravalli at one of my recent appointments drew a chart of sort of the brain and what all the different medications can do for you. And so that really, I don't know why it took me 5 years, but it did. That really solidified a lot of things about the disease-modifying therapies for me. And so I feel for myself, I'm pretty adherent to taking that. Now, the other pieces that he says to do that sort of play into that, I have a harder time doing. So exercise, diet, those types of things. I have a belief in them, but I don't always adhere to those. So
yeah, execution is tough.
Yes, it is. I mean, because it's not only, and I think that when I was newly diagnosed, I'm not sure I would have been able to do some of those things immediately because I was so focused on what's going to happen and sort of the emotional side of it that I wasn't even thinking about exercise or not eating gluten or not eating salt or whatever the case may be.
Yeah, this is Cassandra. I have feel like I kind of have two MS lives in a way, because my first experience with MS modifying drugs, I felt like I needed to be super committed. And so, I was not skipping any injections. I was very, I just felt like it was the only thing I could do to try and control my future, or at least have some influence on it. And so I was extremely compliant. And I think, my second MS life has been through pregnancy. So, I was trying to get pregnant, got pregnant, trying to get pregnant again. I was breastfeeding, and during all of that time, I wasn't comfortable being on any of the meds. I just felt like I had so many questions about, how that would affect the pregnancy and how it would affect the kiddo. And I know that a lot of the MS drugs are, they're not contraindicated in pregnancy, and a lot of them are. So in kind of my second life of MS, where I haven't been taking any disease-modifying drugs for a few years now, the alternative medicines have really been the only thing, or the alternative and complementary treatments have really been the only thing that I feel like I can do, again, sort of like the first time around, I feel like it's the thing that I can do in order to try to influence a positive outcome for me and for my kids. So I am pretty committed to exercise. I am pretty committed to yoga. I mean, I had a neurologist tell me to start yoga, and so I started yoga. I am pretty committed to meditation. I even did, herbal. I saw an herbologist. I did like herbal supplements, which were really, really helpful to me. I've done acupuncture. I've done chiropractic. I've done, massage. So every time I think I experience something like that, I don't really know if it's a placebo. I don't know if it's effective, but if it makes me feel better, I don't really care how effective it is. I feel like, again, it's the best I can do right now while I'm not on these drugs and therapies. It's the best I can do to try to influence a positive outcome. So so I guess that's kind of the approach I've been taking to those things as well.
Right. I was just going to say one more quick thing, please, because you just reminded me of that it's about how you feel. So, some people have said to me, why are you gluten and dairy free, and what's the point of that if there's no research around it, or there's little research? And I said, because it actually makes me feel a lot better. So it feels like something that, like you said, Cassandra, that you can control about your disease and how you feel about it.
Yeah, I think that's really, really valuable and important. Kind of getting back to a point that was made earlier, like if you're taking a medicine that is making you feel lousy and pulling you out of yourself and out of your life, that's not a good trade-off. But if you can do something that makes you feel better all around and potentially have an influence on your disease course, and I say potentially only because we don't truly know, things like yoga and gluten-free haven't been rigorously studied for treatment of MS, and so we can't, as physicians, say, that is, got an efficacy that's comparable to, Copaxone or whatever. But I do think that those are important, and as you say, if it's making you feel better and you're conscious still of things like MRI surveillance and being attentive to the things that you can't see, then I think that's fantastic. Pat, do you have anything to add?
I did, but the thought just went right out of my head.
Okay.
It'll come back.
Okay.
If I can, this is Cassandra. I do think that what you just shared is very, very important, at least from my perspective. I feel a little bit like I'm on a tightrope without a safety net when I'm not on medicine. So it is a balance between, observing the course of the disease, trying not to, trying to have that backup plan. And that's one of the things that, we've talked about in my own care and my own plan for this is, how long is this going to go on? How long do we, kind of rely on the pregnancy protection or, some benefits I might be getting from breastfeeding? And what's the trade-off? Like, what are going to be the triggers? What's the plan B? If this happens, does that mean we're going to go on, a steroid regimen? If this happens, does this mean that, we're going to try Copaxone, which may be safe in pregnancy and breastfeeding? And just looking at the MRIs and trying to make sure that we're not acting as though there's no reason to go back on medicine. It's just that we, for now, are being cautiously optimistic or watchful waiting or whatever you want to call it, and trying to balance all the other things that I want to consider while I'm making that decision about medicine. So I just think your point about watching it and being mindful of that has been the thing that's kind of been reassuring to me.
This is Pat. The point that I wanted to make earlier was, I think there's a big difference between being able to do that now, since you're 15 years into MS and you know what you're looking for and you know what you're doing, and you have some strategies and you're calm enough and solid enough in your MS that you can exercise and do yoga and do all of those things. I think there's a difference between how you can handle it now versus how you could handle it when you were newly diagnosed. And I think it's a lot harder when someone is newly diagnosed to be able to keep all of that together without the kind of net of medication around it.
Yeah, that's a great point. I don't think I could make these decisions even 5 years ago. I really think you're right. It's a lot more about knowing myself better, knowing my disease better, and then again, going back to the doctor-patient relationship, trusting my neurologist that she's going to give me the best advice possible, but she's also going to take into consideration, some very real concerns I have, and not treat those like they're not important to me and that they're not going to influence whether or not I'm going to adhere to a medication regimen. So. Yeah, it's just such a great point, Pat. You're right. I don't think I could have done this 5 years ago.
You have MS and you have a life, and sometimes one is more important than the other.
Right.
Really, yeah. Mm-hmm. And figuring out which one has to take precedence.
Mm-hmm. Right. All right. Well, I think we're getting close to question and answer time, but before we get there, I wonder, Pat, if you'd like to address some of the psychological issues that go into adherence or non-adherence with disease-modifying therapy.
Yeah, I think there are a lot of different kinds of issues that affect whether or not people continue to take medication or even start to take medication in the first place. And I think when people are newly diagnosed, one of the really difficult things about MS, and I'm not telling anybody anything that they don't know, when you get diagnosed and it's really scary and you have all of these symptoms, we use symptoms as a measure of how we're doing. So just like you use pain as a measure. So if you have a broken arm and then it stops hurting, eventually you figure that your arm is better. If you have a symptom and it goes away, you think you're better. And I think when people are diagnosed and they have a lot of symptoms and the symptoms go away, the motivation for staying on the medication can really evaporate, because I think MS can feel so unreal. Mm-hmm. I felt really horrible and now I feel fine, and you want me to spend $6,000 a year and take shots all the time? Are you kidding? Mm-hmm. Yeah. So I think that early on in the disease process, it can be hard for people to get on medication because it doesn't seem real. But I think when people get on medication, I think the statistics are in the most discontinuations starts in the first 18 months. Mm-hmm. So if people stay on it beyond that, then they tend to be pretty adherent. So I think people can not get on medication or not be willing to stay on medication because they don't believe they have the disease, or they don't see the benefit of the medication, or they just don't want to have the disease, or they think that if they stick their head in the sand it will go away. There isn't a lot of, I don't have a lot of good things to report about that. Usually it doesn't go away. But what's interesting to me is what happens when people have been on medication for a while, and then sometimes they stop taking it. And sometimes it's, as in the case that you're in, Cassandra, where there's a really good reason for stopping and people stop, and it's a part of a strategy. Sometimes, though, I think what happens is people accidentally stop taking medication, and I see this happen all the time, where something happens that interrupts you're taking medication, you get flu, or you get something, or you're traveling out of the country, and you don't take it for a while. And then nothing happens. And then it's sort of easy to forget to take it occasionally because you're out of the habit. And then all of a sudden, 6 months can go by and you realize that you've been off the medication and it wasn't a conscious decision, it just sort of happened. Mm-hmm. And then I think what I've noticed in some people is they get not exactly provocative with it, but they're just they're kind of playing chicken with it. Can I do this? Can I get away with this? Am I going to get caught? And that tends to take place outside of medical surveillance, is my experience. So they don't talk to their neurologist about it. And I think that does happen. I think people want to know what's going to happen if they're off medication. I wish that they would talk to their doctors about it so someone can monitor what's going on. And I think, Terry, that's a point that I wanted you to bring up. Because it does happen that people don't take medication. Mm-hmm. But you need to know that because you manage them differently. Is that right?
Oh, absolutely. Yeah. One example comes to mind, and I'll tell the story just because I think it illustrates the point that one of my patients who is on an oral medicine that was supposed to be taken once per day, reported great adherence to me, but had 16 enhancing lesions on her brain. And so that kind of prompted whoa, oh my gosh, okay, you're telling me you're taking this medicine. It must clearly not be working. Let's put you on a different medicine. And then, 2 months later, the reveal was that, well, I hadn't actually been taking that daily oral medicine. And so, we've already kind of made decisions together based on information that isn't representative, isn't correct. And so I think it really is important to kind of, level with your neurologist and admit, it's not a bad thing if oral medicines are not for you, It's just we need to take all of those things into consideration and find the best medicine, and the best medicine is different for each person. It's whatever you feel like you can incorporate in your life and doesn't make you feel like a different person.
I think, though, that patients are sometimes afraid of being in trouble with their doctor. Mm-hmm. So how do you handle that?
Yeah.
And that they're going to get fired, or they're going to get sent to their room, or I don't know, they're going to get the car taken away, or grounded or something.
Well, and we've talked about that, and I think that is sort of a hard thing to combat on anything other than an individual scale. I mean, that's something I kind of try to work with my patients on by saying, we're a team, we're working on this together, this is not a patriarchal society here where I'm just going to vomit information on you and you're going to enjoy it. So I think that is can be kind of a style thing, and I don't know if all physicians feel or are. I think all physicians probably feel that, but may not express it in quite the same way. I think, part of it is sort of proving by example that okay, I'm not going to take away your privileges because you missed your, fingolimod last Thursday. So it's sort of, working through some things together and making it an open experience for sharing.
Yeah, when you read the literature on adherence, it tends to be in couple of camps, and one of the camps is if you don't take your treatments as prescribed, you're a bad patient. And the other is if you don't take your treatments as prescribed, there's a disconnect between you and your healthcare provider, and you need to fix the disconnect so everybody can be on the same page, and you and your physician have to understand together what you're trying to do here. I think it is important to make the point that sometimes people make a conscious choice not to take medication, and that's a conscious choice that people can make.
Mm-hmm.
That's
Yep.
something
Yeah,
you decide.
Yeah.
Cassandra, were you going to add something?
Yeah, I really appreciate the conversation. Obviously, from my standpoint, if I couldn't talk to Dr. Schreiner about not being on medication, I'd have to find a different doctor, because my choices at that point are, either find a doctor who is willing to talk to you and give you some strategies and help you through that, or what's the point of seeing the healthcare provider in the first place? So, for me, it's not about not wanting to manage the disease. It's, there are other reasons why I'm doing this right now and not being on medicine. So I think it goes back to finding the right person, the right doctor to talk to you about that, because they can help you. They are part of your team. They are part of your care. And, I think this is just true for patients in general, but I've learned this, and I talk to people who are newly diagnosed, and I just can't reiterate this enough. Even though we have advocates who are helping us, it is our job to say, this is my life, this is my disease, and these are the choices I need to make, and I need your help to figure out what's the best way to manage it. So, if I can't have that conversation with my doctor, then it's really a waste of both of our time. So, if I'm saying to my doctor, I'm choosing not to be on my drugs right now or on my medicine right now, and, my doctor is giving me some sort of a indication that that's not going to be acceptable for our relationship, then I would really say that's a red flag, and people need to find the right person to talk to.
Right. I think it goes back to the trust, like you said, and this is Susan, and the just having that relationship. I was talking to someone who was newly diagnosed recently, and she said, I'm not going to go to my neurology appointment because I don't know what to talk about. And I said, well, you should probably find a new neurologist because there are tons of things to talk about being newly diagnosed. And if you don't feel, I think it was more of like a comfort thing and a trust, issue. And so I'm the same way. I can't stress enough for newly diagnosed, well, for anyone really that has MS, to find that person that really fits your needs.
Yeah, great points. In the last couple minutes, I wanted to bring up just a few other things. And I know, Cassandra, you're going to have to leave shortly. So do we have any questions that are specific to Cassandra? Not yet. Okay, great. Sorry, not great, but we'll go forward. In terms of the disclosure to your physician, one of the things that I've noticed from my patients is occasionally sort of a sheepishness about admitting to non-adherence. But also the cost issue is not trivial. And I've found there's sort of a lot of, sort of discomfort, like talking about the fact that, my $500 copay every month is really burdensome, and so instead of taking my medicine every day like I'm supposed to, I started taking it every other day, because then I'd only have to, pay so much so often. And that is, I think, so unfortunate, but it is the world that we're living in right now, where each of these medicines that we use has an average wholesale price between $66,000 and $86,000 per year. That's the wholesale price. Nobody pays that, but that's ludicrous. I mean, that's amazing. And what that means is, insurance companies raise prices and copays are raised and so forth. And so it really does become onerous, and it's a real issue that can affect adherence. So maybe we can talk a little bit about some strategies for adherence. And this is just a list that I came up with. This is not a prescription, and several of these things we've already talked about, like the physician-patient communication, and recognizing where it's important to make a change in either who your physician is or what your medicine is, because those changes can positively affect adherence. Using technology, so programming your smartphone to give you an alarm, or beepers, whatever technology you may choose. There is that sort of ability to rely on it in so many different ways, including reminders about medicines. And then some of the behavioral interventions that I've seen work are tying the medication to something that you already do. So if you eat breakfast every day, then it would be a great thing to make your once a day, pill part of breakfast. Or, likewise, I know people that keep the bottle by the toothbrush because they reliably brush their teeth twice a day, whatever. But it is difficult to build a new habit, and it does take at least 20 days. And so that is a difficult thing, particularly in the beginning and when you get out of your habits, difficult to sustain. I think involving family members I've seen be an important technique, because then you have accountability and support. And that is important to know that you're not in it all by yourself. And then the last one that I just had a discussion with one of my patients on Tuesday about is rewarding yourself. It's okay to give yourself a little treat after you've had so many days of great adherence or whatever. The treat is customizable and hopefully isn't very salty or processed, but whatever it is that will sort of reinforce that, yep, this is a good thing and it's okay, and I'm working towards something, even if it is like a little tangible little treat. So I don't know if any of those strategies have worked for either of you, or if there's anything, Pat, that you wanted to add on that topic.
I think involvement of family and family support is really critical to helping people stay on a program. If your family doesn't support you, that makes it really hard. And sometimes, sadly, you can have people around you who don't understand much about MS and suggest that you treat it in a different way, or why are you wasting time with those shots? And I just think those are good people to ignore.
Yeah, I mean, I would just reiterate that, involving your family or even a friend in that treatment program. My husband always gave me my Copaxone shots, and we would make it part of a routine at night, like, hey, it's time for bed, yay, it's Copaxone time, and try to have a little humor tied to this very serious, disease. But, and he really got, a kick. He's an engineer, and he really got a kick out of the auto injector. So you could, tie some humor to the auto injector and in that way. But yeah, I think it's just important. And then rewarding yourself. Now I think Cassandra mentioned massage, and I actually do a massage like once a month, but I treat it as something that I've done for myself, because I'm not only dealing with this disease, but I'm also taking my meds and trying to.
Great point. Yep, absolutely. Are any final points before we wrap it up? All right.
No, I think it was a great conversation. I enjoyed it.
Yeah, me too. Thank you so much to our panelists, Cassandra, Susan, and Pat. Thank you so much. I think this has been a really interesting discussion, and I hope that it's been helpful to people who have spent the last hour with us. Thank you for joining.